Good evening, everyone. Welcome to this webinar. My name is Dr. Beatrice Omari. This webinar is under the Kenya Diabetes Study Group group of webinars in collaboration with the Kenya Association of Urological Surgeons. And today we have the pleasure of having Dr. Anthony Nderitu with us. Dr. Anthony Nderitu is a urologist by training from the University of Nairobi, and he currently works at the Nakuru Teaching and Referral Hospital. He's privately consulting at Preston here in Nakuru, and also consults at various facilities within Nakuru County. So Dr. Nderitu will take us through this topic, lower urinary tract symptoms in males, a contemporary multifactorial approach. And this is a follow-up of a previous urological series where we had talked about sexual dysfunction. Dr. Thank you for agreeing to do this webinar with us, and kindly you can take the floor. You're welcome.
Confirm I'm audible, Dr. Omari?
Yes, you're audible.
Thank you. Thank you for the introduction, and thank you for welcoming me to this forum. Like you said, this is the beginning of a urological series that we hope will be proceeding as we move throughout the year. So today, as we see, our topic here is about lower urinary tract symptoms in males. We are not forgetting the females, only that today we are going to focus about the males. Other subsequent topics will cover females. So the aim today is to discuss lower urinary tract symptoms. You'll hear me say or abbreviate that term to LUTS. And we want to move beyond thinking about just the prostate and to see how else to treat this patient holistically by addressing the systemic, metabolic, and infectious drivers in the male patient. So yes, so this is a paradigm shift, like I've said. Historically, for LUTs in males, we have always associated the lower urinary tract symptoms with BPH, or benign prostatic hyperplasia. And this is where now it became associated with the mechanical plumbing in quotes issue. And urologists have been sometimes in social places referred to as plumbers because of the same. But the reality is that there's more to lower urinary tract symptoms than the prostate. And we find that the bladder, being the reservoir for urine, having a role to play. And sometimes we do have issues with the bladder, like the true of activity or underactivity that can present as the LUTS. And we may also have systemic conditions that may predispose to a patient presenting with the same, as we are going to see in our discussion. When you look at LUTS epidemiologically, we see that the burden cuts across. Looking at the continent, we find that there is high prevalence across multiple cohorts. For the different regions, we find that the prevalence is quite high. As you can see, for example, here in the Republic of Congo, the prevalence is above 70% in men more than 40 years. The age progression rises to over 14% in men over 70 years. And so we see that the aging male is a proponent of LUTS in our society. We pay the urban penalty in that the urbanization also drives the urological morbidity. And urbanization acts as a force multiplier. One, we find that there is diet transition, where we have a lot of processed foods that act as bladder irritants We also have the low water intake among those in the urban centers. There's the industrial toxins, which we find in water, that may also act as bladder irritants. Urban dwellers are also seen to be more sedentary, to lead a sedentary lifestyle. And we have also noted that urban dwellers have higher sexual networks. So the high partner turnover predisposes to infections and other causes of lower urinary tract symptoms. The primary complaint has been majorly reported as nocturia, which is the most troublesome, probably because it impacts the quality of life the most in terms of sleep disturbance and fatigue. When you look at the pathophysiology of LUTs, again, it's not just the prostate being the barrier. We have the reservoir, which is the bladder, and the conduit, which is the male urethra. For bladder, we usually have the storage symptoms being described to indicate the bladder irritation. And for the storage symptoms, we usually have the three main symptoms, which are frequency, urgency, and nocturia. And we've said that LUTs are commonly associated with the aging male. And with the aging male, we have the increased production of neurotransmitters, which gives the outcome of bladder hypersensitivity and therefore bladder overactivity. On the other hand, we have the aging male also having an enlarged or an enlarging prostate, which now presents with the voiding symptoms or the obstructive symptoms. And the four main ones are the weak stream, intermittency, straining, and incomplete emptying. So we see that the prostate has two ways of causing obstruction, which one is the static obstruction by shear growth of the prostate, that is hyperplasia of the stromal and the epithelial cells. Then we have the dynamic component, where you have an increase in the smooth muscle tone and urethral resistance. Systemic diseases also contribute to the LUTs. Some of them include diabetes, where you may have an individual having polyuria. And polyuria is usually described as a daily urine output, more than 2,800 ml. And then you have the description of nocturnal polyuria, where more than a third of the daily urine output is produced at night and is usually often independent of the prostatic obstruction. When we're talking about the systemic conditions, we have the non-communicable diseases, which are a major contributor to the urological decline, hypertension, diabetes, obesity. And we see that these diseases have various ratios in terms of risk to the urological decline. Cardiac disease is shown to have more than 3 times risk, while diabetes has been shown to be more than 2.5 high risk in terms of urological decline. And the mechanisms are quite a number, but those that have been variously described include the chronic systemic inflammation, the autonomic nervous system overactivity, and hormonally stimulated prostatic stromal growth. How about the male who lives with HIV? This individual has been found to have a unique lower urinary tract symptom profile. And we see here the disparity in terms of prevalence. There is a disparity in that the male living with HIV is 57.8% compared to 20% of those in the general population will present with LUTs at some point in their life. And the drivers of their severity include the duration of drug use. We see those who use drugs, the ARVs, for more than 10 years have an increased risk of severe lower urinary tract symptoms, while those who are at later stages of the disease have an increased risk up to 2.4 times. The symptom profile usually find that they have significantly higher rates of voiding issues and storage issues compared to the general population. And therefore, these are individuals that maybe during their clinic visits, should have screening in terms of their lower urinary tract symptomatology. We see here a graph on the distribution of lower urinary tract symptoms, and nocturia also features very highly, as is complained by the general population as well. There are four main mechanisms of HIV-induced urological morbidity, and one is a direct viral impact, where we have the virus affecting the central and the peripheral nervous system, which usually leads to a neurogenic bladder dysfunction, even in those individuals with suppressed viral loads. These patients also, with their low immune status, they have heightened microbial virulence and high chances of getting recurrent UTIs. Three, you have the cumulative long-term medication effect. Some of the older medications like Indinavir had a direct link to urolithiasis. Then four, you have the increased susceptibility to their typical pathogens like schistosomiasis and tuberculosis. The symptoms that the patient will come and present to you at your clinic is just a tip of the iceberg. And this is largely driven by the cultural barriers that we have, where the African man views the genitourinary symptoms as a taboo. And therefore, discussing some of these symptoms with the clinician is seen as a sign of weakness. And we've heard of cases where patients will refuse to even have a DRE as a barrier. Number two, we find that there is a cumulative stigma. As we've seen, there is the intersection of the HIV stigma and the embarrassment that it creates. And this further delays care for these patients who may have these symptoms. Then the nocturia, as I've said, which is the primary or the most common symptom that is reported, heavily disrupts sleep, which further drives clinical depression, further reduces libido, and this becomes like a cycle and often further delays care, which we see here has been reported in up to 87% of symptomatic men within our region. So this is something that we should take note of and try and create a safe space for men to express themselves. So once you have the patient in front of you at the clinical setting, how do you approach the diagnostic pathway? One is a history and a physical examination. The history should be detailed, covering the symptomatology, the duration, the severity, should include any chronic illnesses that they may have, whether they have any medical medication that they are taking, whether they have had any surgeries that may impact on their urological life. Sexual history is important. Again, it tends to be embarrassing for the African male to answer some of the questions that you may have on sexual history. So it's all about creating a safe space to have your patient open up to you to get clues as to what the symptoms may lead to. There is a validated symptom score that we use for patients who we suspect have BPH. It's called the IPSS score, the International Prostate Symptom Score. It is an objective tool. Ideally, should be administered ideally it should be given to the patient to self-administer, such that they respond, they read and respond on their own. But we tend to find that we've made it subjective in that the clinician is the one that presents the question and the patient responds. Physical examination is mandatory, including the general examination and specific examination to the genitalia or to the pelvic area. And we should not shy away from asking a patient their consent to have a DRE to evaluate their prostate for prostate disease. Then you may have to do a urinalysis to rule out infection. And this is available and affordable. Then if you're planning treatment for a patient that you may feel down the pathway you're investigating for something specific, you may include these other recommended tests. One is the bladder diary. The bladder diary, we usually, as urologists, we administer it to the patient, usually filled over a duration of time. There are some specifics that the patient should fill in, including the volume voided, whether there are instances of incontinence, whether there are instances where they had the micturition episodes. They should give us a number in terms of how many times they've passed urine during the day. We have the serum PSA, which is a cancer screening tool. We do have the post-void residual volume, and this is usually indicated in a kidney, ureter, bladder, and prostate ultrasound. And then you may have the uroflowmetry, which usually of urine flow. And the target is to categorize these fluids. For those patients who are suitable for primary care, they're usually treated at the general practitioner level. For those who have complicated LUTs, these are patients you may consider to consult a urologist or refer to a urologist. So these are the complicated LUTs or the red flags that may prompt you to consult a urologist or refer to a specialist. One is a suspicious DRE. What is a suspicious DRE? That is a hard nodular prostate. Usually when a urologist is doing the DRE, usually you remain objective. Go straight to the prostate, assess the prostate. They may have macroscopic hematuria. This is visible hematuria. When they'll tell you they're passing blood urine, usually the color red. They'll use the term that it is color red. That is hematuria. They may have recurrent UTIs or genitourinary pain. There's a scientific description for a recurrent UTI. That is an individual who gets 2 or more UTIs in 6 months or 3 or more UTIs in a year. For patients with a palpable bladder, this is likely a patient in urine retention and may require diversion, either via a urethral catheter or a suprapubic catheter. An individual with a history of neurological disease, this is a patient either has spine disease, has had a stroke, has trauma to the spine that may lead to some of these complicated LUTs. Is an individual you send to a urologist. And last but not least, an individual who you do your PSA levels and you find that they are higher than normal. So that's a patient you send to your urologist for assessment for prostate malignancy. And the clinical mandate on why we are taking care of these individuals is to protect the upper urinary tract, to protect the kidney. That is usually the goal of managing lower urinary tract symptoms. When it comes to management, there is always room for conservative management, or what we call watchful waiting. So this is for a profile of patients. It's not all patients who qualify for watchful waiting. One is a patient who has mild LUTs. That is, again, you're using the validated tool, which is objective, the IPSS score. An individual who has a score of less than 8, that is 7 and below, or a man who is not bothered by their symptoms. That is an individual you can offer watchful waiting. And watchful waiting means you give them a year and you ask them to come back for a reassessment of their symptoms. For those men who come to you with LUTs, it's always best to give them information on lifestyle modifications. One is on fluid management. Again, we see that nocturia is a primary concern, so ask them to restrict evening fluid intake. To avoid bladder irritants like coffee, alcohol, they may practice double voiding and try to relax when they're voiding so that they ensure complete emptying. And then you may train those with overactive bladders on on some of the techniques to strengthen their hold on urine so that they do not have incontinence. Then we have the medical review where we may have to use some of the medications that I will discuss in this slide. We have the common alpha-1 blockers. An example is tamsulosin. Usually this is to targets the smooth muscle, and we offer this for patients with moderate to severe LUTs. It has a fast onset, and patients usually get relief for the symptoms within days. We have the second class of common drugs, which are the 5-alpha reductase inhibitors, or the 5-ARIs. An example is the finasteride or the dutasteride. And these ones usually target the prostate volume reduction. And they're usually slow onset. So majority of the time for a patient who comes to you, you may start with the alpha blockers. For the 5-ARIs, they are commonly used as combination therapy, where you combine the 5-ARIs with the alpha blocker. That's for individuals with severe lower urinary tract symptoms. We have the anticholinergics or the muscarinic antagonists, and I'm sure we've come across mirabegron. These usually calm the detrusor muscle with active symptoms. The other class of drugs, the anticholinergics, we have the solifenacin, which is also readily available. And usually we start at low doses before dose adjustment based on patient-reported severity of the symptomatology. Then step 3, those who qualify for surgical interventions that qualify absolutely. Those are patients who have refractory retention. That's a patient who has had catheterization more than 2 instances. And despite other management for those who are forming bladder stones, for those who are in renal insufficiency, and for those who have failed therapy as a term is an individual who has been on medication for more than 6 months with little or no improvement in their symptoms. Then the surgical techniques are a variety, which is and am I still there?
There was a bit of echo, but I think you can proceed.
Where did I leave you?
At let me see, what was the last? You had finished talking about the medication, so just the
Okay.
slide after the medication.
Yes. So this is a slide after medical therapy, which is patients who qualify for surgical
Surgical,
therapy.
yes. But we are not able to see the slide,
Yes.
so I think you might have to share your screen again.
Okay. Are we there?
Yes. So
Okay. So apologies for that.
yes,
This, yes, if I may proceed. This slide is on the available surgical options, and there are those patients who qualify for surgery absolutely. There are those patients who have refractory retention. That's a patient who's had diversion by catheter, more than twice without any relief of symptoms. Those patients who present with recurrent UTIs as a result of an obstructive uh, those results, those therapies. Hello?
hello, I think you were having a network issue.
Yeah, sorry. Am I there? Am I audible?
Yes, you are. You can proceed.
Okay. That individual who's had medical therapy for more than 6 months. Standard for those patients who have prostate enlargement is a TURP. And then we have the newer or the more advanced techniques like the Eurolift, the HOLEP, that's the laser enucleation, and the Resume, which is currently available in our country. How do we overcome the challenges in our setup so that we can bridge this gap as we try to improve this delivery to our patients? We find that we have the challenge of severe specialist shortage We have disease presentation. We've seen some of barriers of the diseases. They should check up prostate screening in their
Hello, Dr. Ari. Hello.